pretty significant transition in the healthcare system. Essentially what happened before the ACA was that we had large numbers of people in the United States that did not have health insurance. That comes out to about $8,000 per person in the United States for health care. And that's more than just about every other country in the world. And so that became a big problem for people who were, had healthcare problems. And they said, gee, I got to spend $5,000 before I get healthcare. Well, that's the way it worked. Other people get insurance through what we call the individual market. That's just like where you call up Kaiser, you call up Health Net and say, I want to buy health insurance for myself or my family. If you applied for one of these individual plans, you would fill out a form and how old you are, and then they would start asking you all kinds of questions about your health care. How many times you've been to the doctor, what prescriptions you're taking, have you ever been diagnosed with any of these diseases? And then they would determine, A, if they would cover you, and if they would, how much your premium was going to be based on that information. So that kept a lot of people out of affordable health care. So when the Affordable Care Act was passed, it did a few things. In the United States, we have a public insurance program called Medicaid, and it covers people who are low income. And prior to the ACA, you had to meet certain eligibility criteria. You had to be a dependent child, you had to be blind, you had to be disabled. And so therefore, there were a lot of people who just were not eligible, even if they were desperately poor. Now under the ACA, those rules have changed. So essentially just about anybody who is below, they have gross income below 138% of poverty, which is about $18,000 a year for like a couple. They would be eligible for Medicaid. The second thing it did was create what we call these health benefit exchanges. So this is a private marketplace. If you go onto their webpage, you'll see a whole bunch of different health plans that you can choose. And if you meet the income criteria, you can sign up online and you can get one of these private plans. In other words, you would get a premium, subsidy, but the premiums that you would end up paying would not be any more than about 9.5% of your income. So they structured it as a way to sort of limit how much you were going to spend every month for insurance. So what's the problems with this? First of all, in some states in the United States, they had the option of doing the Medicaid expansion. California did choose that, but in other states they did not. In the law, it specifically says that if you're undocumented, that you're not eligible for any of these programs. There are also people who are legally here. They're immigrants, but they haven't been here for more than 5 years. So if they've been here less than 5 years, they have different rules that apply. People who have higher incomes that maybe have health problems, they can't get into it, they are also excluded. And also, if you're not eligible, if you work for a company and they offer you health insurance and you decide not to get it, you're not eligible for the subsidized plan. So it's not a perfect system. There are people that aren't going to get into it. So under the Affordable Care Act, the insurance companies can no longer use pre-existing conditions to discriminate against you. They cannot tell you can't have insurance, and they can't determine what your rate is every month based on your health status. The only thing they can use is your age, your location, where what part of the state you live in, and your family size. In some states you can use smoking status, but we haven't done that in California. The other important change is that people who are under the age of 26 can now stay on their parents' health insurance.
I'm an emergency physician, and I'll tell you one of the reasons why I chose emergency medicine was because there's this law, and I won't go off on any tangent, it's called EMTALA, which means I really have to see anybody, right? But I can shake their hand and say, you don't have an emergency, and send them away. That's all I have to do by law. I have to at least make sure that there's not an emergency, and if there is, stabilize them. That has changed since the Affordable Care Act, because now I have a large percentage of patients who are undocumented or uninsured, who now have insurance, who can still come to the emergency department, but they can't follow up with us anymore. But the emergency department overcrowding has skyrocketed, and it's always been a problem since the Affordable Care Act. And I'm all for the Affordable Care Act. The more people covered, I'm for, so I'm not against it. But this has been a lot of knock-on costs because there's people who didn't have insurance who now can go to the emergency department.
Well, from a pharmaceutical company perspective, what I saw was that there's more push towards preventive care. So instead of treating disease, pharmaceutical companies trying to develop products to prevent disease. So there is a group of specialists in pharmaceutical industry now looking at the cost effectiveness, and when the guidelines are written, the cost effectiveness is included. That is a significant part of the process. Drugs may be approved, but the guidelines may not be updated. And if they're not in the guidelines, then the insurance company would not cover it, and the patient may not get.
At some point, the U.S. will no longer be able to afford healthcare in its current structure. So a reform is needed. I think ACA is one step toward that. It's certainly not comprehensive, but it's one step toward that.
What you're seeing here is a representation of that change. If you were looking to graduate medical school, do your residency, and hang up a shingle, I'm Dr. Such and Such, come see me, it's unlikely that that scenario is going to happen. And as I said, part of that is because of the Affordable Care Act, but it's just the way that medicine is changing.
About the Affordable Care Act, its impact on private practice, I actually think that's intentional in the design of Affordable Care Act, in the sense that over the past 3 or 4 years, you see a lot of mergers and acquisition. We are all probably going to be in some sort of group practice or large network or plans or entities. And that changes the way you practice medicine. And the reason for that is because really of the economy of scale, right?
Where we've seen that in California, we have like 9 or 10 plans competing. It seems that that sort of competitive market has had some small effect of keeping premiums lower than they otherwise would have been in places where there were fewer insurance companies, like in Iowa, for example. One of the reasons why we're seeing this spike in the insured population going to the emergency room is because we're giving these people these cards. They say, here's your doctor, and then the doctor doesn't know that the patient's in their practice, and the next appointment is 3 months down the line. And so they say, if you need to see somebody today, go to the emergency room. So you're seeing the spike of people who are going to the emergency room, but they don't have access to primary care, and ultimately it comes back to the workforce issue.
So the push is more towards keeping people healthy and preventing disease. And in the long run, preventing these long hospital stays or complicated diseases that require a lot of money, the hope is that it will balance out, and hopefully maybe the premiums will be lower and the costs will be lower.
I was disappointed with one aspect of healthcare reform, and that is that it did not include tort reform, which has to do with our malpractice. So all of these, think of them as levers. We're going to drive down the cost of healthcare. We're going to drive down physician reimbursements. We might even delegate some physician responsibilities to non-physicians like nurse practitioners and PAs. But the cost of malpractice insurance continues to rise. The cost of medical education continues to rise. What the Affordable Care Act in its current form represents half of the government. So not only was half of the government not in favor of it, but they were fighting and continue to fight to get it canceled altogether. So I wonder what would happen if our government got together and decided that we want to make healthcare a national initiative.
Medical teaching and medical schools are changing, and also in other states there are more local medical schools trying to serve their own population, address their own needs. So that's something I think you may see as opposed to just these large medical schools.
This sort of shift from paying doctors to do things to paying doctors to actually get people healthy. We don't know how to do that real well. We're learning how to do it. What are those metrics? How are we going to hold health systems accountable for those things? That's, I think, going to be the biggest impact.
I have patients, homeless, Skid Row is in our catchment area, all this stuff, right? So they come in, haven't seen anybody diabetes, right, sugar, come in, all this stuff, okay? And then they come in, they get diagnosed with congestive heart failure. Congestive heart failure, there's this fee-based thing that you can DRG, right? They get the diagnosis code that's put in there. And if they bounce back in 30 days, we might not get paid for that. So we have to get away from fee-for-service, because fee-for-service, the more you do, the more you get paid. And even if you are a good ethical physician, as most people are, so at some level, that's in the back of your mind. Capitation was a model where they paid exactly what he said, about $500 million. But they say, hey, look, doc, we'll give you whatever it is, $150,000. This is your patients, right? And the less you do, the more you make.
You get everything, but you do everything, including hospital care and hospital costs, right? Capitation doesn't work because they will capitate me for per member per month for how many dollars, regardless whether I see them or not, but they're enrolled to my panel. But I want to do less work but make the same amount of money, so I would do less work. But those costs and benefits are not equalized with the hospital. Whereas if hospital and us share the same risk, meaning that if a patient goes to the hospital, I have to pay hospital a certain amount of money because hospital lose money, right? Then in that dual risk agreement, which is now what capitation is today, I can't just not see a patient and just let them go to the hospital, because I would have to end up paying money at the end of the day for that member, because I'm responsible for their overall healthcare dollars as well, just like the hospital is, right? And hospital want to encourage them to go see their doctor. They don't want them to come back to a hospital or ED, go to your primary care provider, because if the primary care network saves money, I save money. So if you get paid on how satisfied patients are too. So if they're not satisfied, then you don't get certain part of the payment. And then on utilization, meaning that if the patients are not utilizing resources correctly, you get penalized too. It all depends how we structure it. If we structure it very intelligently, it will work. If we don't structure it very intelligently, it's not gonna work.
What would be important for the students to learn is how to communicate with the patients so that they're compliant, they're satisfied. Population is getting older, health literacy, you need to use the language that they understand. So those things are more important today than 5-10 years ago. So that's probably going to be, you'll see in medical school. Another thing would be more managing a team. Again, you heard physician assistants and nurses and nursing assistants. So probably a lot of people will be working with you, underneath you. So how to manage those, how to communicate, manage a team. We're also seeing more and more telemedicine, right? Trying to kind of use technology to get care to, especially in rural areas. So you will see more technology, and you'll have to learn about that. And definitely quality metrics, pharmacoeconomics. So when you're looking at two different treatments, you will have to kind of figure out which one is more cost effective. Maybe you will be making these decisions for your organization, for your practice. So those are the things, adjusted quality of life year. And so it's some of the terminology that comes with pharmacoeconomics you'll have to learn more about.
Some people would say that they prefer, private practice because you're your own boss. You can take vacation whenever you want. If you can hire as many people, as you can afford. But on the other hand, the point that was made about how much that practice is paying for, a package of gauze, that's probably going to be a lot more than a practice that has, 200 groups that are involved in it. So economy of scale, I think, is an important thing. I will say to the patient, well, have you seen your cardiologist? That's the guy who referred the patient to me. The patient says, no, I can't see him because he won't take my insurance anymore. So now I'm a primary care doctor. I'm writing the blood pressure medicine. I definitely think that in addition to that, the way that the Affordable Care Act is set up, there's a push away from referring or contracting with small individual groups towards larger groups. The concept of coverage and scope of practice is important, for that.
My residents will tell me, this is not emergency medicine. This is not what I went into. So I tell the students, I said, look, This is emergency medicine, this is everything, because we see a lot of primary care, right? And I've only worked pretty much at level 1 trauma centers my whole career. So I've seen the sickest traumas, and we love a guy with a knife in his back jumped out of a car. Really, that's what we love. That's what we're looking for. But that's not reality, right? We see a lot of, hey, I need my meds refilled. I can't, or I need a place to eat, or sleep or something like that. And that wears, if you think about physician happiness, there is a pressure because we have a lot of groups. When you talk about a group practice, so they can be these groups, you have a number of patients per hour that you're supposed to see. And if you don't meet that metric, they probably will get rid of you, right? So, but you have to be safe. And I think most people are safe because if you just have to say, you know what, this is not working for me, and get another job, right? It's real. That increased number of patients is real.
So I think one of the shifts that the ACA has not done is helped us rethink how we spend our healthcare dollars towards things that we think will be important to keep people healthy. I think what we need to do is help people become healthy on their own, and think about it as doctors. Ask your patients, where do you live? How much sleep did you get last night? When did you exercise? How safe is it for you to exercise? Can you even buy fresh fruits and vegetables where you live?
Healthcare changed so much at that time, and it's now, I think, going through another change. So this is good stuff. I would urge you to maintain your passion about medicine, but just be educated about what you're going to do, whether it's a specialty or how you're going to practice or even where you're going to practice. State, internationally, you owe it to yourself to be happy with what you're doing. It's a profession that requires quite a bit of commitment.
You think I'm going to do this, but your career may take you to somewhere else. And we all did. So being a physician, I think, gives that basis to kind of also do many other things.
We all appreciate all the time that you've given us. So why don't we give our panelists a round of applause?